How are y'all doing? I'm Nate Menke. I'm the director of the Inpatient Addiction Consult Service at the University of Michigan. And I'll be talking about our kind of similar, kind of a new protocol for the rapid conversion of long-acting opioid agonists to buprenorphine. I have no disclosures. And so this protocol came about due to the current state of the opioid epidemic. So I don't know if y'all are familiar. I'm sure you guys are aware that, over 100,000 people died last year due to opioid overdoses. And we're in the third wave of this epidemic. And what we mean by that is it's now fentanyl. So our patients are, we see about one patient who has true heroin in their urine drug screens a month, and every other patient has fentanyl. And the patients that do have heroin also have fentanyl. And so this has actually created a very, very significant challenge to our service to get patients on buprenorphine for the treatment of opioid use disorder. Even though fentanyl has a very short half-life when used acutely, if you use chronically, it has a depot effect, basically. So we have patients developing precipitated withdrawal up to 3 days after their last injection of heroin, or what they think is heroin, which is usually fentanyl. And so back in the day when it was heroin, you could wait 12 hours and typically induce patients on buprenorphine without risking precipitated withdrawal, but that is absolutely not true these days. Patients are petrified to try buprenorphine because they've done it on the streets. And again, they've had precipitated withdrawal 48, 51 hours post-injection. And so in order to facilitate induction onto buprenorphine, people tried microdosing. So this allows patients to stay on their full opioid agonists, their heroin, and start the buprenorphine without causing precipitated withdrawal. And so this overcame one of the barriers to starting patients with OUD on buprenorphine who cannot stop using, right? They aren't able to make it through this period of withdrawal in order to safely start it. So you kind of skip that by giving really low doses. And you don't get to precipitated withdrawal because you get precipitated withdrawal when you displace a full opioid agonist from the receptor at a significant amount. And so if you do really, really small doses, then you don't get enough of a knockoff effect to cause precipitated withdrawal. And so this is one example of an outpatient microdosing protocol. So the doses we typically use for opioid use disorder is 16 milligrams. So instead of 16 or 8, you can start off with 0.5 milligrams daily, and then titrate up from there. Unfortunately, again, this takes 7 days. It's difficult for some patients to do that. And so what we have started using for microdosing is using a buprenorphine patch. And again, you use the kinetics of the transdermal delivery system in your favor to prevent precipitated withdrawal. And if you look, you can see that you get kind of peak blood levels, I don't know, between 2 and 3 days. And so you put a patch on a patient, you give them full opioid agonists, and then you can wait 12 hours and then give them full dose buprenorphine without causing precipitated withdrawal, even in these fentanyl patients. So this diagram is the 10 microgram patch, and we use 20 microgram patches when we use it for microdosing. And so another strategy has come out in the literature. So again, a patient presents to the emergency department and they haven't used fentanyl for 12 hours or 16 hours. And you can't really do a microdosing protocol on a patient that comes to the emergency department. Like, that's not a feasible strategy. So people have tried macrodosing. And so the theory behind this is that if you give 2 milligrams of buprenorphine, you are much more likely to cause precipitated withdrawal than if you were to give 32 milligrams, because you're able to get enough of an agonist effect at higher doses that will not cause precipitated withdrawal. And so again, this goal of this is to try and prevent that long waiting period that people can't tolerate in order to start buprenorphine. And And again, this is both microdose and macrodosing. There's no big studies. This is all case series. This is all clinical experience. There is no randomized control trials of using any of this stuff. But if you talk to people, they say that you can give 24, 32 milligrams and patients do better than if you do 2, 4, 8 milligrams. So less precipitated withdrawal. And the other nice thing is you're getting a steady state a lot quicker. Buprenorphine has a really long half-life, so it takes 4 half-lives to get to a good steady state. But if you load them up front with 32 milligrams, not only are you getting close, you're getting steady state faster, but you're also protecting the patient, right? So if you fill all the receptors with buprenorphine, if they go out and inject the next day, they are unlikely to get significant effects from heroin or fentanyl. And so we combine these approaches for our patients, specifically on methadone. So this protocol also works for long-acting morphine or oxycodone, but those aren't as difficult to convert. And these are, again, inpatients who are typically there for a week or for whatever reason. So what we do is we apply the transdermal patch, the buprenorphine transdermal patch, 20 micrograms per hour. We apply clonidine patch. Again, it's a central alpha-2 agonist. It helps with withdrawal. It likely helps with pain. We've had difficulty with clonidine as a PRN order because, again, patient never receives it. You ask the patient, like, no, I never got any of that. So if you're not actually telling the nurse to give it, oftentimes patients will not get it. So if you get a patch on them, then they're guaranteed to have some dose of clonidine. And typically what we do is we convert the methadone dose into morphine ER or oxycodone ER, as well as an IR formulation. So again, the conversion of methadone to other opioids is fraught with difficulty. Like it just is, like you're basically just guessing and hoping. And so what we do is we use the conversion factor of 3 to 1, 3 OMEs for every 1 milligram of methadone. And then we cut that almost in half for the extended release. And then we kind of make up the difference with the IR, and that is not scheduled. That would be a PRN medication. And it's very crucial to have sedation hold orders on these patients because, again, you are guessing. And the kinetics of methadone and the kinetics of an extended release, you just don't know what is going to happen. And so then we typically, again, how long we leave them on this patches. For methadone, we try and do it for a full week. Because again, the half-life of methadone, especially on a patient who's on it chronically, could be forever. So 7 days will hopefully at least get 1 half-life. If they were on morphine ER or oxycodone ER, I'd probably only do it 3 or 4 days. I would try and do a conversion because, again, you want the washout effect of whatever chronic opioid they're on. So we can continue with this extended relief until, that should say 9 a.m. on the day prior to buprenorphine macrodosing. So you get 24 hours off the extended release. And we leave the IR on until 9 p.m. the day prior. So you get 12 hours of abstinence. So you've got this abstinent period, but you've also got a steady blood level of buprenorphine at this point from the transdermal patch. We typically ask the teams to give the patient some type of sedative to help them sleep through the majority of this period, which often facilitates this. And then in the morning, we flip to the macrodosing protocol. So we go 16 milligrams sublingual once. We wait an hour, reassess them, give another 8. If they're having any withdrawal symptoms, you're not feeling great, and then reassess them another hour and give them another 8. So total 32 milligrams possibly on the first day. And then we continue buprenorphine sublingual subsequently. And the dose we choose for that, again, is going to be patient dependent. What's their pain generator? If it's OUD, we use OUD in pain, we use OUD dosing. So that's very patient specific about how much we're going to continue. So I'll talk about this in these examples. So for methadone, we like to do it a week. Like if they've on chronic methadone, high dosing, I mean, doing it less than a week just seems dangerous to me. For morphine ER or oxycodone ER, I would probably do 3 or 4 days to answer that question. So here's one example of a gentleman we use this on. 35-year-old male with a history of intravenous drug use, complicated by osteomyelitis of his back. So he had a really significant surgery. and he'd had multiple surgeries in the past. He had a left-sided thoracotomy, arthrodesis, corpectomy. So he had pretty significant postoperative pain. He was put on ketamine. He wanted to be on methadone for his treatment of his OUD, so we used methadone for treatment of his pain as well. And so we tried to titrate it up to OUD doses of methadone. So most patients get benefit between 80 and 120 milligrams for OUD, as opposed to pain medicine dosing, right? He was on hydromorphone, 4 milligrams PO, 3 hours as needed for severe pain. And then on a Friday, he tells us that he has a court appointment on Monday, and that this is after 5 weeks of hospitalization, he tells us this, that he may not be able to stay on the methadone because he may have to go to prison. And so again, he's on 80 milligrams. We titrated him up over a course of 5 weeks post-operatively. And so what we did was we converted his hydromorphone to oxycodone to get a 25% decrease in his OMEs from that. And then we converted the methadone 20 milligrams POQID to extended release morphine, 45 milligrams POTID, right? So like 135 OMEs. And, you were guesstimating around 240 OMEs of the methadone. And again, so he'd been on it for 5 weeks. So what is the half-life of methadone in a patient like this? And again, I don't know. So he did really well in that. We actually dropped his ER dosing on day 3. So again, the morphine levels are climbing as you're reaching steady state, and the methadone levels may not be dropping at the same rate. So you were at risk of overdose on these patients. And again, that's why we have these hold orders. And that's why we prefer continuous pulse ox while we're doing the first few days. And so we dropped him to 30 milligrams POTID. And that day, the next day, he developed some mild withdrawal symptoms that was easily treated with extra clonidine. And again, on the day before we started the buprenorphine, so 6 days into the protocol, we held his extended release in the morning, gave him IR at 9 p.m. and then 9 a.m. the next day, we gave him 16 milligrams of buprenorphine, and he had 0 withdrawal symptoms and minimal pain overnight. And then for him, we put him on, I think that says 8 milligrams sublingual QID. So we started off on a higher dose just because, again, this was a stressful situation and that he could be down titrated. So this is kind of the maximum dose you would even consider doing in a patient for OUD. And again, a patient like him that is very unstable, who's been injecting heroin forever and has, again, multiple back surgeries, we felt it safer to go the higher dose. Yes.
Down there, I call about 500 more
Mm-hmm. Yep.
Up around,
yep.
Linear,
yep.
Yep. 60 of oxycodone. So you're around 500 more or less. You put it all that to more.
Mm-hmm. Yeah. He was. So again, I think. Well, it's because you're not, because the methadone's not being metabolized. Like you still have that methadone background, and then the buprenorphine is coming up. So it's a very complicated pharmacokinetic. Yeah. Yeah, for the analgesic effect, yeah, that's why we split at QID.
And then using that as a bridge to then on the opposite.
That seems a little trickier just because the methadone is so long acting. Yeah. I know. I mean, again, it's every person doing what, it's a wild, wild west out of there, right? There's no studies. You're just doing what you can to try and help patients. So if it works, great. I don't get it either, right? And so this other guy demonstrates kind of why we do it the way we do it. So he was admitted for being a 59-year-old guy with history of opioid use disorder. He's been had injected 12 years, but he's been on methadone for 12 years. And so again, he was on 90 milligrams of methadone, stable dose for years, but he couldn't no longer attend methadone clinic because he couldn't walk because of these venous stasis, and he had to take 2 buses, right? The problem with methadone clinic, right? It's really, really hard to get to. It's a huge barrier to maintaining treatment. So despite the fact that he was 100% stable on this medication, it was working well, he could not continue it because of his social circumstances. And so he was admitted for a totally different reason, but they consulted us to try and help get him off the methadone. And again, so we did this over a week again. So we converted, again, the morphine to 45 milligrams POTID and put the patch on, put the clonidine patch on. And so so on day 2, he was a little sleepy. I'm like, yikes. You know, even though, again, we cut his OMEs really, really hard, right? 45 milligrams TID of morphine from 90 milligrams of methadone. So there was a big cut, but instead of having withdrawal symptoms, he's having overdose symptoms. Because again, a patient on 12 years of methadone, the kinetics are so wacky, like he's just has depot effects and you just don't know. So he became oversedated despite this huge cut. So we actually had to cut his dose. We cut his dose intentionally because he was becoming progressively more sleepy. And so again, on day 6, we stopped his extended release morphine. We gave him a couple of doses of IR morphine that day, 9 p.m., no opioids. Next morning, 9 a.m., he got 16 milligrams of buprenorphine, didn't feel well, got another 8, didn't feel well, got another 8, so got 32 milligrams. Next day, he still wasn't feeling great. And when I say not feeling great, I mean, he's having like diffuse body pain. He was really like, you know, kind of just restless is, I guess, the best way to put it. It looks almost like an akathisia, that you could tell he was having mild opioid withdrawal. He wasn't having nausea or vomiting or yawning or rhinorrhea, but he wasn't feeling right. And so at 48 hours, his pain was gone, his withdrawal symptoms was gone. It was the best he'd felt in a while, and he was up and ambulating without any difficulty. So he was a little harder, I guess. Again, he had just saturated his whole body with methadone. So he definitely had a more difficult course than the guy who'd only been on it for 5 weeks. And he also was on the way to overdosing based on our cut, because again, that methadone metabolism was so slow that I don't even know if he made it to a whole half-life, in a week. And so that was just kind of 2 examples of what we've done and why we're doing it. Methadone is just a tricky one to get patients off of. We have much more success with, extended release morphine, extended release OxyContin.